That was a good advertisement. Thank you, Eve. So cool. Okay, and now I have to get started. Where do I click? There we go. Cool. Okay, so I was asked by Tim to come along. It's great to be here. Thanks all for coming and listening. And I was trying to make this pretty low key, so because I'm just a simple surgeon, and so this is not going to be a bit like Marion's complicated talk. Actually, it's going to be quite simple. And I was really hoping that I'd have plenty of time at the end for people to really ask their questions, because I don't know what are the things that you've come along here that you want to know. I'm really hoping we'll have some time at the end where you really can ask, and I'll do my best to answer some of them, and Eve and other folks here who are experts as well. So I think I can go down here. So this is fixing the plumbing. I actually Googled it. I'm getting better at Googling these days. I learn off my teenage sons who spend all their time doing it. And I think here's a New Zealand plumber who's having a go. He's quite a nice looking guy. So this is the sort of trouble otherwise we can get into. And you can see, actually on the bottom corner, you can't quite see it, but this is actually Melbourne plumbing. This was Melbourne plumbing. But actually I have to admit that we actually do, you can have both ways. So there's a huge variety in doing the Fontan procedure and getting it right. That's one of the stories about this. There's so much to say, I'll just try and cover a wee bit of it. But basically, the fundamental thing, so the only thing I'm really going to talk about in terms of development, embryology, diagnoses, is that essentially when you're doing the Fontan, you're doing it because you can't septate the heart. You can't divide it into right and left. You've got some missing parts. Usually if it's just a connection problem, you can rearrange that and get that fixed back to right and left. But if you've got missing parts, something very small that hasn't developed right, then you've really usually got to do the Fontan. So the babies have had shunts or bands or the Norwoods as newborns, or maybe nothing's been needed until they've got a little older. And then when they're in a few months of age, a bidirectional Glenn, a cavopulmonary shunt, a hemifontan, those are all kind of names for the second stage that's usually done. And that's done to allow lung development and growth of the child to about the age of 2 or 4. During that time, your main aims are to protect the heart muscle from damage. So a lot of focus on that, to develop good pulmonary arteries so that there's a really nice pulmonary artery tree on each side leading into the little alveoli, the lungs. And you want to deal with any arch narrowings or valve leakages as well in the time leading up to the Fontan, so that really everything else is set up as perfectly as it can be for the Fontan. And in our service, usually we then do this catheter study about 18 months or so now after the Glenn, or in the lead-up stages before the Fontan. And this is we do it just to find out quite a lot of things, so that we really have set the scene, so we know we've got a good situation for the Fontan. Although not absolutely everybody does this now, so as I say, everything's changing, but it keeps moving on. But I just wanted to explain this, and some of this will be new to some people and old to others. So if you've got blue blood, and Kate, who's currently on duty over the way, the registrar helped me draw this. If you've got blue blood coming down here, usually with a bidirectional Glenn arrangement, the SVC's been sewn onto the pulmonary artery there, so that pressure is going to be about 12. That's about the mean pressure it takes to push blood through a toddler's lungs. And so that's blue blood. The saturations may be 55 or 60%, oxygen saturations in that blood if you measure it. Okay, so that's blue blood there. You've also got blue blood coming up from the IVC here into the right atrium, and that pressure is only about 7. So our right side of that side of the heart will usually function at a pressure of about that. It's quite a lot lower. The saturation's a little bit better, 65. So you've got that blue blood, and it comes across the atrial septum here and into this left atrium. Same pressure, because there's a hole between the two now. But that mixes with the red blood that's coming back from the lungs, saturating at about 98% or 100%. And then you get this purple blood then mixing in the ventricle and pumping out to the body. So your body blood pressure, 90/50. your body saturation, the arteries will have a saturation of about 82%. So roughly, there's all sorts of anatomies that can end up with the bidirectional glen and needing the Fontan, but roughly most of them all end up with this kind of arrangement where firstly the pressures in the upper part of the body are elevated, and secondly the saturations are reduced. So that's the reason why you want to get on and do the Fontan procedure eventually, because usually if one of our aims in our practice is to try to restore normal oxygen saturations to the body, and if you do that, you tend to get a better exercise tolerance. The children can have a longer exercise capacity for longer, so they don't just do short spurts, they can play the whole game of soccer or whatever. They also have better concentration. They also have improved resistance to infection and better healing of wounds and things. So overall, if we can restore oxygen saturations to normal, we should. And then also in the longer term, when you have a mixed circulation like you saw in that diagram, there is a chance of clots forming in the venous side of the circulation, which we do to a certain extent in adulthood without even realizing it happens. And normally if it happens to us, if we're sitting on a plane for too long, the clots can't go anywhere except into the lungs. They just go through the right heart and out to the lungs. But if you're a bidirectional glen, or you still have a right to left shunt somewhere in your body, then the clots can go through here, and they can go out here, and they can go out to the body, and they can cause quite a lot more trouble, particularly if they go to the brain. So those are some of the fundamental reasons why we aim to do a Fontan procedure if we can. Over the years, there's been a lot of varieties of Fontans done, and from way back 40 years ago, this kind of Bjork modification was done. Sometimes you could actually sew. So these are people who didn't have a tricuspid valve, it was blocked. So we were trying to figure out a way, the surgeons were trying to figure out a way of getting the blue blood to get to the pulmonary arteries and go straight through there. And initially, this was how it was done. And really, the right atrium was either sewn directly onto the pulmonary arteries, or a conduit, a homograph, was put between the two. Or else the homograph was put between the right atrium and the infundibular part of the right ventricle before it led into the pulmonary arteries. And that got blood going to the lungs, and it worked. Later on, people developed this sort of Fontan called the lateral tunnel Fontan. And lots of folks have grown up with this sort of Fontan. So the bidirectional glen is done here, and then the SVC is actually sewn to the underneath of the right pulmonary artery with a little bit of augmentation sometimes just to make it a little bit bigger. And that's the a Gore-Tex baffle is created on the inside of the atrium, which tunnels IVC blood so that it can no longer go that way and into the heart. It has to go straight up to the SVC and then into the pulmonary arteries. So that's called a lateral tunnel Fontan, or total cavo-pulmonary connections, another word for it. Thanks to Melbourne for producing these lovely diagrams. And then finally, the Fontan that now is the dominant one around the world is this extracardiac Fontan. And for various reasons it was devised. There's technical reasons why we do it, and I'll explain a little bit more about that. But essentially what we now do is sew a Gore-Tex tube from the inferior vena cava, so it's taken off the bottom of the right atrium. That end is over-sewn here, and this Gore-Tex tube is attached up here and up to the undersurface of the right pulmonary artery. The Gore-Tex tubes vary in size. I've got one here, so if anybody wants to just feel what the Gore-Tex is like, I thought I'd just hand those around. There's a shunt and a tube. You can pass them around. They're beautifully silky and soft. It seems to be a material that gets a nice thin lining over it, but doesn't get lots of chunks and things on it. And it can do a nice curve without kinking off, and you can sew it. And we try to put in about a size 20, if we can, 20 millimetres in diameter, which if you're putting it into a 3 or 4 year old is actually quite a lot bigger than their IVC, but as the years go by, obviously it ends up slightly smaller. If we're doing one of these in an adult, we'd put in a size 24 millimetre tube, so not much bigger. And obviously in some of the younger children who need it at an earlier stage, we have to use a smaller tube. So when we do the Fontan operation, there are definitely some early complications, and in the earlier days these were quite troublesome, and we've learnt ways of managing them. The output can be quite low, and there can be a lot of fluid drainage from the chest drains. Heart rhythms sometimes go out of coordination, so the atrium doesn't beat with the ventricle, they beat out of sync with each other, and that means we lose some output and blood pressure as well. Sometimes the kidneys reduce their output as well because the heart isn't pumping enough blood through them. Sometimes there can be stasis developing in the venous circuit, and then it can start to clot, and that can be really troublesome, and lung infections can intervene. So these early complications made the Fontan quite a high-risk operation in the very early days, but mostly that has now been, we've learnt through the things to do to help, and now, as Eve said, our survival is much better than it once was. The reason why it's a bit of a dangerous operation, or it used to be until we figured out how to do the physiology, was because if you think about it, once you have this extracardiac arrangement, basically the only way blue blood can get through the lungs and back to the heart is through these passive systems. So there is no longer a right ventricle pumping the blood through. It's got to flow relatively passively, or kind of like be sucked through into the lungs. So blue blood coming that way, blue blood coming out that way. So you've got these saturations 60, 65, and the pressure in these veins tends to get a bit elevated from what it's used to being. So it'll be up at 12, as I say, 12 or 14. And there's a lot of things that can make that pressure go even higher, and then the circulation starts to not work very well. If it pushes up to 18 or 20, then we start to get into trouble. So what are the things we've learnt to do? Does that diagram, I hope it makes sort of sense to you. You've got the blue blood there, you've got the red blood coming back here, and you're no longer mixing anything between the two of them. So you have got the saturations up to 95 or 100%, like we aim to do. So how do we avoid complications? Well, the first thing is to make sure we select the patients well. So we do those catheter studies and make sure we've figured out that there's no other things that we can improve on beforehand. Look after the ventricles, look after the pulmonary arteries and grow them. And sometimes our cardiac interventionists will put stents in to make the pulmonary branches bigger, or they'll put coils and things in to reduce the collateral flow, which are little extra arteries that go into the lungs and can really make them flood, especially after this Fontan surgery. But one of the main things we've done is learnt to do a fenestration or a detour, so blood can bypass the lungs if it needs to, especially in the early phases as they're recovering from the Fontan. So this is this little thing here after the extracardiac conduit, where you create a little hole in the conduit and you sew the side of the right atrium onto it and create about a 5mm opening there. And so the blue blood running at slightly higher pressure here, say a pressure of 14 or so as you finish the Fontan, fizzes through into the atrium, which is running at a pressure of about 7 or 8, and a steady little bit of blood manages to get through that way. So even if the lungs are a bit sticky and the resistance in the lungs is up a little bit while the kids are on the ventilator, hopefully still blood will get through to the left ventricle and it will have some blood to work with. So we tend to select who we do fenestrations for, but anybody who's we feel that the risks are increased, we'll put in that sort of fenestration. So the other things we've done intraoperatively to keep the risks down are to keep the heart beating, which is something that you can do when you're doing the extracardiac Fontan, because it's on the outside of the heart. You can use clamps, you work around the outside of the heart, you mostly don't have to stop the heart at all. The heart is emptied, so the bypass pump is used and it's taking over the circulation and pumping the blood through the body, so the heart's kind of deflated, but you just push it a bit to one side. It doesn't have to do any work, but it's beating, so there's still a blood flow going through it the whole time. You haven't stopped it. So it'll work better after that surgery. We keep the patient warm, and that helps us avoid transfusion, because blood transfusions tend to make the lungs resistance go up a little bit. We take care of the conduction system, so we've got good rhythm after the surgery. Try not to damage the SA node, the top bit of nervous tissue that's starting the conduction through the heart. If there are any pathway narrowings, we attend to them. We put patches or plaster them so that we can create as streamlined a pathway as possible, but not too bulgy. You want it, if anything, narrow, not with bulges and things in it and too many twists. And we also use modified ultrafiltration, which is a form of like a dialysis thing on bypass, where we filter out some of the inflammatory mediators, the chemicals that the body makes in response to bypass, which tend to end up, again, raising the resistance in the lungs, making it a bit harder for that blood to go through easily. And we measure the pulmonary pressure at the end of the surgery and have a low threshold for fenestrating, so adding in that hole if we weren't going to do it anyway, if we are concerned about the patient. So I guess this is what it looks like in the operating room. And to start with, you tend to think, you guys, it's just all about the surgical team, the people actually doing the operation, but actually it's a really big team of people, and actually even all of them aren't in here. There's often 10 or 12 people in the operating room, and the patient's in here somewhere, but there's anaesthesia team. There's the bypass team. You can't even see the perfusionists here running the bypass pump. There's scrub nurse and circulating nurses getting things and going fetching things. There's heaps of pumps for perfusing inotropes and drugs at the end of the procedure. There's a big team to achieve a good operation. That's one of my main messages here. At the end of the surgery, there's a number of things we know to do now to make the Fontan go more smoothly. The first is early extubation. So when you have a Fontan circulation and you don't have a pump pumping the blood through, what you need is to suck the blood through, and the heart does that a bit, so when it's functioning well, it actually creates negative pressure, if you like, at the end of the circulation, at the end of that passageway. But also your own ventilation, your own breathing, as you suck breath in, you're actually sucking blood in through to your lungs from the rest of the body, I guess. So when you're on a ventilator and you're having positive pressure ventilation, that automatically works against the circulation. So it's really a good idea for any of these children to get them extubated early. But you still don't want them wild, obviously, so that's quite a skill in that, getting them in intensive care nursing, getting them looked after carefully so you can still monitor all those numbers and pressures, you can still have them comfortable but breathing well. And it's really quite a skill to do that. It's much harder than actually just having the patient quiet and asleep for the first night. We also use atrial pacing for slow rhythms, so we keep the rhythm synchronous. And then when children are awake, we encourage them to breathe deeply. We try to get them out of bed into a chair within the first few hours, in fact, and walking around, standing up, taking deep breaths, because it is, again, it's part of what will make the circuit work well. Later on, we also optimised nutrition, because with this circulation, they're losing pleural fluid, they'll lose fluid into their tummies as well for a while because of that extravenous pressure they've got in the lower part of the body, and that's protein loss which you need to replace. Early survival, I put over 98%. Hopefully it stays at 99%. That's what we aim for, or even better. But you can expect, when I talk to parents, I always warn them, it's going to be 2+ weeks in the hospital with the chest drains. However, they will be racing around on the little bike that we have in our ward, because with the drains in the boot, because actually they'll be feeling better almost immediately. They'll be pinker, they feel better straight away. It's really nice to see. So in spite of the fact that the drains are a nuisance and they can be a bit sore, actually they'll be feeling better. And we tend to do a catheter study 2 or 3 weeks after the surgery if the drainage is not slowing down and we're not looking at getting the drains out. Because sometimes we do find collaterals or other aspects of the repair that we can deal with in the cath lab. So in the late outcomes, this is all about the registry, and this registry is extremely valuable. I think, in my international meetings I go to, people are so jealous of what we've got here. It's just something that you've got no idea how lucky we are to have this set up by Eve and the group here who've done all the work for it. But it's basically going to be able to show us not only how well Fontana children now, doing now. But as we follow through the long term, it's going to tell us what surgical techniques that we've already used and that we may then plan to use in the future, and what medical treatments are really going to be useful or not. And believe it or not, there's not a lot out there otherwise to really guide us. You know, we a lot of these things we follow from best principles or other areas, but this is really going to tell us what's best for Fontan, for single ventricles. The circulation is so very different from a normal circulation. We've got to learn a lot about it, and the learning's going to keep on happening as the people who've had the Fontans get older. As we're really recognising now that many of the organs in the body are affected in the long term, in spite of them having the better oxygen levels, the extravenous pressure and perhaps some of the other things about the circulation that we don't fully understand are going to affect organs in the body in the long term. And so we're going to keep on our toes. We're going to need all the help we can and all the science we can to decide what are the best things to do to help look after these people as we grow up. If you have an early Fontan, this is an atriopulmonary Fontan, you can end up with a great big atrium like this. This is like a slice through the body this way, and this is the ventricle of the heart, the thicker walled chamber, and this is the atrium. So one of those old atriopulmonary Fontans, they get dilated. So like one of these, the atrium gets really big because it's under this pressure of 12 or 14, or maybe it gets a bit higher as you get older, and it balloons out. Well, atria weren't made to be under that pressure for the long term. So this is why we've done these Fontan modifications over the years, and some adults have the Fontan conversion operation to get rid of that dilated atrium, often get rid of the arrhythmias that go with that, with cryoablation, which is using a freezing probe to make lines in the atrium, and sometimes putting pacing leads in and a pacemaker to keep the rhythm steady. There's lots of new techniques out there and people trying to do things in different ways, and I don't know a lot about these. I hear a wee bit about them. I'm a little, just still listening really to what other people are doing, but people are doing the Fontan off bypass altogether, so they just use clamps and pieces of tubing to divert the blood flow and don't actually use a bypass pump. The advantage to that, I guess, is that you probably need less blood, and also that you might not have as much reaction or inflammatory reaction as you do when you go onto the bypass pump. But I think there are risks as well, so I haven't actually tried that myself. There's also catheter intervention Fontans coming through where you can set up the circulation. I'll just see if I can go back to a picture. Here you can set up the circulation a bit like a hemi-Fontan, like a... So you're like here, but you actually sew that to that, but leave a platform there, and then the interventionist can come through later, come up here and put like a covered stent all the way up through to here. So you don't actually have a surgical Fontan, it's all done through catheters through the groin, and a tube is put in. And again, that's an interesting thing to keep an eye on and see. But it's all about, in the end, making sure that you've got really good laminar flow. So this is just to remind me to tell you about the studies of Marc de Laval, who's a surgeon in London, where he's been studying for quite a while how to make the flow as laminar as possible, because we haven't got a pump to blood through the lungs. So what we want to do is really make sure that the flow can go as smoothly without any turbulence and without any hold up, with using as little energy as necessary for the long term. And this is a diagram of suggesting that you offset the SVC a little bit from where you put in the IVC and the Gore-Tex, and looking at various ways in which you should do that. But certainly the passageway that you create as a surgeon, I think, is very important, and how smooth you make it. So in conclusion, for fixing the plumbing, well, there's still an evolution of the Fontan procedure, but very much the initial management sets the scene. So the management of the baby, the infant, I think, managing, looking after the heart, developing those lungs, that's really one of the most crucial moments. It's very much a team effort, starting from the fetal cardiologists and the neonatologists through intensivists, paediatric cardiologists, cath interventionists, nurse practitioners, nurse specialists, anaesthetists, imaging experts, parents is a big deal, play therapists, surgeons, and I'm sure there's other people I've left out of that list of people. And I think that the ANZ Fontan registry is going to be a remarkable tool for learning, and I think it's very, very important to keep participating, so thank you. Now, I have got a video here which I think will play if we've got time. Have we got time, or do you want to have this during the break or something? This? Okay. That's a yes. It's actually 8 minutes, and it's still in draft form, and it's been developed to teach the children who are coming in and the families who are coming in about the Fontan journey. Tribute to Julie Stubbs, our nurse specialist who's put a lot of work into this, and also Andrea Newlands from the Starship Foundation, and the family who you'll recognise here, who offered to let Cam be photographed for it. It has got sound. Hopefully that's going to come. Here we go.
Cameron Bartle was born with hypoplastic right heart syndrome, or in other words, he was born with half a heart.
He's missing the right side of his heart. For us, the right side does our lungs and the left does the rest of our body. So he's trying to live with half the capacity that we have with a whole heart.
He had his first open heart surgery, a Norwood procedure, when he was just 5 days old. At 15 weeks old, he had his second surgery, called a Glenn procedure. And now 3-year-old Cameron is returning to Starship Children's Hospital for his third surgery, a Fontan. When a baby is born with parts of the heart missing, there is no operation that will repair the heart to a normal arrangement. However, after the third operation, the Fontan, the circulation is set up in the best way possible to allow Cameron to have oxygen saturations in the 90% range. This will give him the best chance of a good quality of life. Better oxygen saturations mean children have more stamina, better concentration, and better focus. The Bartles kindly offered to share their family's experience to help others going through a similar journey.
We were never told what to expect, and so it was horrible. Yeah. It was horrible. There was our little brand new baby lying there on a ventilator, you know.
Hard to put it into words, actually.
Yeah.
When you look back at it, very hard to put it into words.
We've kind of lived a bit of a sheltered life for the last 3 years, really.
Because he's really had no immune system.
But now he's had this next surgery and he's well again, we'll be able to have a normal life. I guess now we're nearing the end, like this is the third one and hopefully, fingers crossed, the final one. Yeah, we can kind of look forward now. We know he's in amazing hands, definitely, and we do have full faith in Kirsten and the team. But, yeah, I guess we're very anxious and apprehensive.
Nervous.
Yeah, very nervous.
Scared.
But, you know, he's done it twice before, so... And this time he's way bigger, way stronger, and, you know, there's no way he's not coming home with us. Why are we at Starship, Cameron?
I'm fixing my heart.
I'm Nadine Chapel-Toy. I'm the surgical booker here at the cardiac department in Starship.
Before coming to Starship, the surgical booking administrator contacted the Bartles to discuss Cameron's planned surgery date, flights and accommodation, arrival time at the ward, instructions for medication, and any last-minute changes. Once the family arrived at Starship, they settled in and started to make preparations for surgery. Once at Starship, there are a range of different steps in the journey. Cameron's echo ultrasound is reviewed.
I'm Kirsten Finucane. I'm one of the surgeons here at the Starship Hospital, and I do children's heart surgery. What we now need to do is to channel an inferior vena cava, which you can't see here. It's not had any dye injected into it, but it's down about here. And what we need to do is connect it up also to these lung arteries. And probably what I'm going to need to do is actually divide that stent a little bit and sort of splay it open so I can put the Gore-Tex tube into that, the extracardiac conduit. So that's the job for tomorrow.
Once Cameron is admitted to the heart ward, he meets a lot of different people. He has an ECG tracking to check his heart rhythm. The nurse checks his vitals, such as his oxygen saturations, blood pressure, and heart rate. Cameron has a finger prick blood test to cross-match his blood for his operation, check his electrolytes, and do a full blood count. A play specialist uses play to normalize some of the things Cameron will soon be experiencing. A nurse practitioner outlines what's involved with the Fontan procedure and explains that Cameron will have nilled by mouth for 6 hours before surgery. Just before surgery, the anesthetist visits to obtain consent. On the night before and the morning of surgery, Cameron has an antiseptic bath, gets into a gown, and takes a sedative to ensure he is calm before going to the theater. Dad Nick accompanies Cameron down to the theater, but Mom Rachel prefers to kiss Cameron goodbye on the ward. Cameron is in theater for the best part of the day. Several hours of pre- and post-surgery procedures, as well as 3 hours of surgery itself. During surgery, Cameron is on a heart bypass machine, which takes over the work of the heart while the surgery is taking place. Once he comes off this machine, a nurse calls Cameron's parents from theater to let them know he is off bypass. When the surgery is finished, Cameron is moved to PICU, Starship's Pediatric Intensive Care Unit. Soon after, a PICU nurse calls Cameron's parents to let them know they can come and see him. Cameron had some complications post-surgery, which required some extra procedures and a longer than expected stay in PICU. Finally, Cameron is well enough to go back to the heart ward. The nurses help him manage his pain with medications and with wound care, so he can start mobilizing and doing deep breathing exercises. The nursing team teaches Cameron and his family about medications and monitoring post-surgery. For some surgeries, children need to be on blood thinners such as warfarin and will need regular blood tests to monitor this. In some cases, families are taught how to do this at home. And finally, when it comes time to discharge Cameron from Starship, his nurse takes time to talk through all the issues that the family will need to consider once they're back at home, such as home care, nurse visits, wound care, medications, exercise restrictions like avoiding pulling the arms, and impact activities such as trampolining until fully recovered, follow-up appointments, and returning to daycare or school. Once the family returned home to Hawke's Bay, life started to return to normal, and Cameron continues to do well.
It was just amazing to know we were home. We'd done it, and yeah, he was alive. That was the biggest thing. Yeah, I think now it's finished and over with. We need to move on as a family again, try to get Cameron back into a good eating pattern and building up his strength again, and slowly reintegrating him back into kindy and all that sort of stuff.
Yeah,
but
and Corey too.
we're very grateful, aren't we?